The agenda for the next 90 minutes is to let you know about some of the background of our work, go on to talk about the two phases of our project, phase 1, which Gilles will talk about, and phase 2 that Susan will, followed by presentations, both case presentations and studies by the panelists. I'm going to close with a few minutes of other considerations that relate to what we're doing, and then I hope to have some time for comments, questions, and answers, because as you'll see, what we're doing started out very much as a grassroots effort, and we want our work product to be useful to the community. We want to hear from you what will help you in thyroid nodule classification. I will start off with introduction and background. My disclosure is that I have no disclosures. Starting off with why is this important? I think everybody here knows, we've heard it many times at the meeting so far, is that thyroid cancer is overdiagnosed. Seeing here the curves from the Korean experience showing a rise in the diagnosis of thyroid cancer with effectively no change in mortality. And this has been highlighted in multiple publications, including this one, lead author Megan Haymart, talking about the screening that took place in South Korea with no net benefit for patients. What do we all need? Well, we know there are lots of nodules out there. I'm a radiologist, and it's unusual. I call residents over when I see a normal thyroid gland because it's so unusual not to see any nodules if you look hard enough. And we want to know which ones are malignant, and more specifically, which ones require fine needle aspiration or other biopsy. That's led to the development over the years of multiple systems for risk stratification and management. And my journey down this road started in 2004. I was involved in the development of the Society of Radiologists Ultrasound consensus criteria that year. And then I led the committee at the American College of Radiology that developed the ACR TIRADS system. And this is the ACR TIRADS chart. I'm not going to go through it in any detail, but suffice it to say that it's achieved fairly wide adoption among radiologists in the US and elsewhere, and it's a points-based system where each feature is awarded a number of points ranging from 0 to 3. You add them up and come up with a level that guides management. The reason we did this is we wanted to prevent this sort of stuff, and these are almost verbatim from radiology reports I'd seen in my practice. Here's a bad one, a 1.2 centimeter solid nodule in the left lobe is amenable to biopsy. Well, almost every nodule is amenable to biopsy, so that's not helpful. Even worse, a 0.7 centimeter complex nodule in the right lobe cannot rule out cancer, okay? And still worse, or horrible, dominant nodule in the right lobe correlate clinically. And again, I didn't make these up. These are things I was seeing in radiology reports from outside institutions mostly, and something we wanted to help prevent. There are multiple scoring systems and guidelines that have developed. I've only listed 14 of them here over the years. The first system to use the acronym TIRADS was developed by Eleonora Horvath and her colleagues in Santiago, Chile, back in 2009, and they chose that acronym based on the very successful breast imaging system used for breast imaging since the 1990s. And of these 14, there are this many that I've highlighted in bold yellow that are TIRADS, so there's a lot of TIRADS out there. And they have a lot in common other than the fact that they all originate from the same planet. This shows some of the features in the 5 feature categories that we used in ACR TIRADS, and I've highlighted in yellow or orange, however that appears to you, the intermediate suspicion ones and the more suspicious characteristics in red. But these aren't anything new. These are the same types of features that were found in the other systems as well. Here's the EU TIRADS chart. Again, very, very similar approaches in terms of what features are being looked at. And here's the ATA chart from 2015. And I'm going to superimpose on them all the ones that I just highlighted are identical to ACR TIRADS, same management. These that I've highlighted, these three, the only difference is a 0.5 centimeter difference in threshold for biopsy. We went half a centimeter higher in ACR TIRADS. These, for what we would call TR3 in ACR TIRADS, the difference was in biopsy threshold was greater. And these last few are ones in ACR TIRADS which we wouldn't recommend biopsy for at all. But the reason I'm showing you this is that there are more similarities between this system and ACR TIRADS, and indeed between all the systems, than there are differences. A very interesting study published in Radiology earlier this year by Dr. Ha and colleagues looked at the differences between the systems in terms of nodule size thresholds for biopsy. And they essentially did simulations looking at what would happen if they changed the size thresholds for the Korean system and for the ATA. And in terms of unnecessary biopsy rate, by manipulating those numbers, they were able to bring the unnecessary biopsy rate very close or essentially identical to that of the ACR TIRAD system. Again, more similarities than differences. That led me to think about a year and a half ago, could we come up with what might be termed a universal TIRAD system, something that could be adopted worldwide? And I know this is sort of an aspirational idea, and I'll tell you a little bit about how I went about it, but it would only apply here. This picture was taken by the Cassini probe from Saturn. Here's Saturn's rings up here. That's us, 900 million miles away. So every system in the world will only apply on that blue dot. I don't know if that makes our task any easier or any harder, but it points out that we all need to cooperate because this is all we've got to live on. That led over subsequent months after about a year and a half ago, starting in September 2017, to my emailing, calling a bunch of people and saying, would you be interested in working together? And to my great pleasure and surprise, they said yes. And that led to many thousands of emails and calls and such, and to the formation of the, I have no way to pronounce it, the International Thyroid Nodule Ultrasound Working Group. I did try to make a pronounceable acronym, but I failed at that. And the structure and governance is simple. We have a steering committee, 80% of which is here today, and work divided into two phases that you'll hear about in a moment. These are all the associations that are represented in the steering committee, which has 10 members. And these are the members of the steering committee. Again, 8 of us are here at this meeting today. The fact that these organizations are represented does not mean that whatever work product we produce will be endorsed by them. And we knew that going in, but we felt it was important to have each of these organizations formally appoint people to the steering committee. Phase 1 projects will include developing a lexicon of ultrasound features and building an online image access atlas. And Phase 2 will include determining the risk ranges of cancer for each risk level, how to map the features to risk levels, and guide management. And finally, also doing validation and publication. So with that, I'd like to invite Gilles to come up and talk to you about Phase 1.
Thank you, Franklin. Good morning, good afternoon. I've just walked. Everyone. So I will be reporting on the Lexicon, which is Phase 1, but much organization was given before that. And what, first of all, are the Lexicon aims? It is to define a standardized terminology, a common language. This is in order to increase Interobserver agreement in reporting US features and to ensure consistency in recommending biopsy. Indeed, we still have variability in interpreting thyroid nodule US features, and this remains high. I'm going to give you the example of this very interesting report, which was done by Jenny Hwang and colleagues, published in the AJR in 2018. It was very interesting because they interrogated a panel of 8 radiologists on 100 cases, and 6 of these 8 radiologists were non-specialized ones, and they were in private practice. And the results was that the Interobserver variability, especially for margin and echogenic foci, was only fair. And that's a real difficulty because these 2 US features are key ones in all our risk stratification systems. On the contrary, shape and macrocalcifications had substantial interobserver variability. So the authors concluded that we had to put lots of educational means and research specifically on margins and echogenic foci. What tools are we using in this working group? First, of course, emails, as Franklin said it, and conference calls. Then Franklin really set up 2 very interesting tools, which one of it is a forum where we can exchange ideas on specific topics, and the other one is a share file account to deposit all the reports we are going to use and the pictures. It does not go that well, I'm sorry. So we are using a Delphi methodology to build this lexicon, and probably phase 2. And what is a modified Delphi methodology? It consists basically to perform a poll, and then on specific questions, collect the answers, and then study if we have reached a consensus, and we have put this to 80% as a cutoff. If consensus is reached, everything's okay. If it is not, we will ask the question again by rephrasing it and taking into account all the remarks that were made until we reach consensus. So that's basically the way we work. We used that process. By that time, it was only the steering committee, the 10 of us, to define the categories that will be in the lexicon. Composition, echogenicity, shape, margins including halo, echogenic foci including the macrocalcifications, extrathyroidal extension, and lymph nodes. All these reached more than 80% consensus and thus will be included in the lexicon. But on the contrary, flow and elastography only reached a 70% approval and thus were not retained, and I think this will be debated later on. To constitute the subgroups, all associate members were co-opted by the steering committee during voting procedures, and this was to include a broad spectrum of viewpoints and representation and an odd number in each of members in each subgroup to simplify voting. Now, these are the subgroups. There are 4 of them. Echogenic foci and microcalcification, shape margins, composition and echogenicity, and extrathyroidal extension and lymph nodes. And you can see that for each subgroup, there is a leader and 4 other participants. So this is what we're discussing by now, the writing process methodology, its summary and agenda, because we will be entering this very shortly, I hope. So I suggest identifying key focused questions, both by defining which terms we want to study, and the Interobserver agreement of it, to perform an extensive literature search and to add the articles provided by members, then to assemble a library that we can have on this share file account, and to organize it by terms, then distribute it to the subgroup members. The members will have 1 or more terms to work on, and then they can suppress the irrelevant articles, assess and rate the retained articles using the grade method, which is basically based on both the methodology and the amount of cases. and then write the definitions. And then we will go through that Delphi process again to rate the definitions until we reach consensus. Thereafter, we can issue the lexicon and incorporate it to the guidelines. So this is what it could look like. I took the example of ecogenicity, so probably there will be some kind of, general definition for each term, and then descriptors. In that case, it could be hyperechoic, isoechoic, mildly and markedly hypoechoic, and comments if needed. So finally, how can the lexicon help solving difficulties in thyroid reporting? Well, to my mind, the first thing to do is to really come up with very precise definitions. And this will be very important, especially for echogenic foci and margins. But this is not sufficient. It is of utmost importance that we build an online imaging atlas freely available and linked to every definition so that everyone can really understand what the verbal definition means and not only words. Hopefully, this will enhance Interobserver agreement. That's it. Thank you.
So phase 2. So phase 2 will be implemented after phase 1. So I'd like to share with you some general ideas that we have about phase 2. Because one of the things we recognized is that it's very important to come up with this atlas, but we'd like to make it, give some guidelines for use of it. And when you start to think about how you use sonographic imaging of nodules, you use it many ways, because you use it to decide about FNA, but not every patient is the same. So how can we begin to give guidance about personalization and individualization? How can we start to talk about follow-up? And how can we potentially push the field forward? So the plan would be we would develop this robust 4-level risk stratification system based upon sonographic appearance. However, we recognize that people get to that level different ways, and we all know this. ACR TIRADS is successful. It's based upon sums of points assigned to various features, whereas most of the other systems are based upon a more holistic description of the nodule. And we certainly recognize that methodologies have a tradition, and radiologists, because of other types of BI-RADS, are used to this points assignment. So in other words, we're in Rome, and all roads lead to Rome, and you might take a slightly different path, but you would get to the same place. But in addition to coming up with what will then be a composite of these 4 robust levels associated with risk, we wanted to then provide general guidance both for FNA as well as for surveillance. And lastly, we wanted to at least provide some discussion of other factors that go into those decisions about FNA or follow-up. And those factors, as I said, can be involved with the patient, it can be involved with the culture, and certainly with the medical resources. So just to summarize in a slightly different way, what I've done is I've taken the guidelines that are represented by the 4 groups who are part of the steering group and actually part of the larger group as well, the ATA, the Association ACE, the American Association of Clinical Endocrinology, the ATR, the ETA, and the Korean Society for Thyroid Radiology. And you can see some are at 5 tiers, and some are at 4 tiers, and some are at 3 tiers to begin with. And these are basically what you all know. These are the current risk stratification levels and the names in all of these associations. But if you look at the first level where it says benign, that's really the absence of a nodule or a pure cystic nodule. So we're already at 4 of these associations are using 4-tiered stratification. Now, how do you assign nodules into risk-based categories? Well, 4 of them are already pattern-based, and one of them, as you know, the ACR, is the sum of the points. So again, we would preserve the history of how people get to Rome. There might be a slightly different path, but again, having a 4-level risk stratification, and the way you can get there is potentially by looking at a picture or by using the sum base of points. When we talk about size cutoffs, as Franklin said, all of us who do this already know that there's 85 to 90% concordance, at least in the imaging. And certainly there's a lot of concordance in FNA cutoffs. There are some small differences. And I think the most important thing when I talk about nodules is we have a number of nodules for which now we have removed the possibility of FNA. We've actually recommended not to FNA. And what I've shown here are, in these systems, the ones where no FNA is actually explicitly stated. Then we have a couple where you're given the option. The ATA says you can FNA at 2 centimeters for the spongiform nodule or not FNA. And ACE has, for a low risk, you would only FNA if it's growing. The Korean Society is FNAing these more low-risk nodules. And then you can see as the risk increases, the size cutoffs decrease. And there's certainly a lot of concordance, so by the time you get to the highest suspicion pattern, every society is recommending an FNA cutoff of 1 centimeter or greater, with the asterisk that you would even potentially FNA a sub-centimeter nodule under certain circumstances, for example, like metastatic adenopathy. So you can see they're already pretty similar. But what we would really like to do is to try to allow for this flexibility and individualization, looking at patient-specific factors. And age is obviously a big one. Many of us who are in the nodule field often quote the recent article from the Brigham that looked at FNAs in patients over the age of 70, where they had close to 1,200 patients, and there were only 17 high-risk thyroid cancers identified, and all of them could be identified by ultrasound. And the question is, are we really doing a service as we start to continue to FNA patients over a certain age when other tests like colonoscopy and mammography are not even done? Medical comorbidities. To take that into account, and we'll talk a little bit about where that discussion is. Risk factors for thyroid cancer, should this be a modifier as well? Should we be changing cutoffs if there are certain risk factors like head and neck radiation in individuals under the age of 18? Family history, clearly defined as more than 2 to 3 relatives. Genetic syndromes like FAP or Cowden syndrome that can be associated with differentiated thyroid cancer. And in addition to the incidentalomas on PET scan, what about those found on gallium? And I'd like to bring all of your attention to a very recent article by Dr. Beck and his group that has actually very nicely shown that even if a nodule has uptake on FDG PET, if it is TR2 or TR3, ATA, very low suspicion or low suspicion, the risk of cancer is not changed. So in other words, that really gives you the evidence to state that if you have FGG uptake in a spongiform nodule, that perhaps you could just follow the general guidelines of all 5 societies and pretty much leave it alone. So our current guidelines, what I've done here is just to give you a starting point of where we're coming from, looking at age, medical comorbidities, other DTC risk factors, and we don't have the data yet for these on dotatate, although the literature has shown that there's probably about a 20% risk of malignancy in nodules that take up dotatate. You can see that especially the Radiology Society, which was really, again, that system was designed for radiologists who are not the primary clinicians involved in the care of those patients, doesn't include any of those in the discussion. When you get to, for example, some of the more clinical societies like the ATA and ACE, you can see that there is inclusion and discussion of the medical comorbidities and some of these other modifiers. The ETA really came up with an EU TIRADS. They were not doing a nodule guidelines. The purpose there was to come up with a sonographic classification system, so that's also not considered. And the Korean Society has a couple of those as well. But in general, we have a lot of room where we can really do a much better job of looking at the literature and trying to provide the data about how these factors might modify FNA cutoffs that might otherwise just be based upon the risk of malignancy by sonographic appearance. And in addition, medical cultures are different. Any of you who've been here for the last 2 days have heard about differences, for example, in the management of micropapillary carcinoma. So there's certainly values and practices within a culture and within the medical or surgical culture of that particular culture. And we know about resource availability. There are additional topics, though, that we would like to include. So how do you approach multiple nodules? How many do you report? How many do you biopsy? how do you follow nodules that may not meet the criteria for FNA at the time of the initial diagnostic ultrasound? How do you follow nodules with benign cytology? That actually is consuming a large number of healthcare dollars currently. And then lastly, sort of on an aspirational list, is how can we use cytology perhaps as an adjunct to molecular testing to modify risks associated with indeterminate cytology? So if we look at where our current guidelines stand for guidance about reporting the number of nodules, I have to say that for the two American societies and the Korean society, basically there's no limit. You're supposed to potentially report all of the nodules that you see in the thyroid. There's no guidance to say only report a certain number of nodules. The American College of Radiology does give a limit, and you only report those that meet the FNA criteria, and you report fewer than 4 for follow-up, so more prescriptive. And the European Thyroid Association recommends that you report at least the 3 most important. And that's the quote. So we certainly have some room there. And then how many nodules do you biopsy, even if there are a number that meet FNA criteria? And you can see there's a lot of variability here as well, with 3 of our societies having no limit for the number of nodules to biopsy if they meet criteria. If we then talk about the guidelines that try to address the use of sonography for follow-up recommendations. First, if we look at which guidelines even try to tackle what you do with nodules that may not meet FNA criteria at the time of the first diagnostic ultrasound, you can see that 3 of the societies don't begin to tackle that. 2 of them do. And again, there's very little evidence here, but I think Cosimo Duranti and the group from Italy will give us some more evidence by the time we are writing this. But the ATA gives us just recommendations for the first ultrasound. At least the ACR gives us a 5-year plan, but again, very little evidence behind that. And the situation that does consume a lot of healthcare dollars, how do you follow that nodule with benign cytology? Some recommendations, but very, very limited. So again, I think a couple of years have passed since most of these guidelines, and we can try to review this and to include that as part of this process. Thank you.
Thanks, Susan. Now we're going to proceed with panelist presentations in alphabetical order, starting with Dr. Beck.
Good afternoon, ladies and gentlemen. I'd like to talk about ultrasound features of growth, extrathyroidal extension. This is my COI. As you know, tumor size and growth ET is important for decision of tumor management. So today I will talk about ultrasound diagnosis of T3B and T4A. That means strand muscle invasion, trachea, and recurrent laryngeal lobe invasion. We used surgically confirmed cancers in 2017 in our center. About 1,600 patients were enrolled in this study. In terms of T3B, we divided ultrasound features into 4 types. First one is abutment of a tumor to thyroid capsule. Second, you can see the capsule disruption. Echogenic capsule is disappeared in this point. And the protrusion of cancer into the strand muscle. And finally, do you see clearly? Here is the tumor and the replacement of strand muscle by tumor. That is defined. Tumor protrusion and the margin of the tumor is indistinct or speculated with the strand muscle. Dim the light, please. So here is diagnostic performance. You can see the capsule disruption. In this case, shows highest sensitivity, and the replacement of strap muscle shows highest positive predictive value. What do you think about this one? Which is important, sensitivity or PPV, for deciding strap muscle invasion? Dr. Lupor, could you comment on that?
Yes, thank you. I think the sensitivity is more important because it clues the clinician and the surgeon into the possibility of strap muscle invasion. And with invasion, you might have more of a need to do cross-sectional imaging for a CT with contrast preoperatively to not be surprised intraoperatively. So I would think that sensitivity would be more important than PPV for this strap muscle invasion question.
Any other opinion?
To be honest, I use these features the other way around. If there is no capsular abutment, I can assert there is no invasion. But these features have low positive predictive value. The high predictive value is the negative one. So I always describe the capsular disruption, so to tell the surgeon, and of course the replacement of strap muscle, as Mark said. But
Yes,
that way it doesn't work.
Yes, thank you. Any other surgeon? Comment from surgeon?
As the surgeon on the panel, I would agree with both comments that it's more important to have a high negative predictive value. The positive predictive value is less important, but sensitivity would be more important in even raising the suspicion and prompting either surgical preparedness or further cross-sectional imaging.
Any other comment from the floor?
Well, Jung, what is your opinion about the sensitivity for the posterior invasion? Because for the surgeon, probably this is the major problem. That is, well, a good surgeon can remove without great problems a muscle that is partly invaded. But the great problems, I suppose, come when you have a posterior adherence to the fascia.
Yeah.
Okay.
So I think the same factors prevail, except that the risk for extrathyroidal extension in the posterior visceral direction is worse in terms of prognostication and risk of surgical lack of preparedness. So even greater necessity for sensitivity in that direction. And that's combined with the fact that posterior extrathyroidal extension is more difficult to assess in many instances of ultrasonography of thyroid nodules, especially as they get larger and extend more posteriorly or posterior to the air-filled structures or bony structures in the neck.
Yes.
Okay, thank you. Any other opinion? No, from the floor? If you have any different opinion, you can choose. If you think sensitivity, you can choose this finding. And if you think PPV, you can choose this finding. So let's move on to T4A. This is Japanese study. They divided 3 types of ultrasound features for tracheal invasion. And the last one, obtuse angle, they regarded a high risk group. Their result shows tracheal shaving or resection is almost always in high risk group. This one, obtuse angle. So they suggest this is a real tracheal invasion finding on ultrasound. What about our result? We also divided the 3 types: acute anger, right anger, and obtuse anger. So our data shows tracheal invasion. That means tracheal cartilage resection or shaving was necessary in all patients with obtuse anger except one patient. And the sensitivity of this finding is around 92%. So what do you think about which is important, sensitivity or PPV?
I think for the reasons that we mentioned previously, that sensitivity is the most important, and this shows a very high level of sensitivity. I would like to just put a pitch in for the something that's not discussed here, and we haven't really discussed as a group yet, but that is the dynamic, interactive nature of ultrasonography, which allows for palpation of a lesion during the performance of the ultrasound exam, which can give information into the likelihood or presence of invasion or not. In other words, if you palpate the nodule as you're doing the exam and it is mobile with respect to the trachea, that can provide reassurance that the trachea is not invaded. That's something I think we're going to have to consider discussing as a group, which is a dynamic feature not really addressed in static characteristics.
I agree, and I think this discussion highlights the fact that what we're aiming for is more than just the nodule characteristics by themselves, but looking at the nodule's relationship to surrounding structures, which I think is, from reports I see, is often given short shrift or not mentioned at all.
Yes, thank you. Any other opinion?
It's quite interesting.
Sorry, besides what Lisa said, and I really appreciate what you said about the palpation, is that when you're looking at this feature, for example, and you're looking at the anterior capsule, you can't overemphasize the importance of cine or real-time imaging, because to actually make sure that you've actually imaged the nodule in its entirety, so you've been able to assess the capsule anteriorly or the posterior borders. And so looking at a single static image and relying on somebody else to have captured that static image for you to then be able to make an assessment about the capsule or about the angle is probably not adequate.
Yes, thank you. Any other opinion from the floor? No? So we also, sensitivity is more important for tracheal invasion finding. What about the recurrent laryngeal cancer? This Japanese study divided into 2 categories. You can see the first category shows the normal thyroid rim is present between the tumor and trachea, and there is no normal thyroid rim. And this is regarded as a high-risk group. So they found recurrent laryngeal lobe resection was only observed in this high-risk group, this one. So what about our one? We divided into 3 types: preservation of normal thyroid parenchyma and abutment of tumor to tracheoesophageal group and protrusion. So we found recurrent laryngeal lobe resection was only found in protrusion group. So the diagnostic sensitivity was about 82% in this finding. So I introduced today 3 ultrasound features of growth. ETE, strand muscle invasion shows high PPV, replacement of strand muscle finding, and these findings shows high sensitivity for trachea and recurrent laryngeal lobe invasion. Thank you.
Our next presenter So the way, I really have to thank Franklin, by the way, organized this. We should all thank Franklin on our panel. Franklin and his wife went on a lovely vacation, and while he was away, we were all sending him our presentations, which he managed to get together without ruining his vacation at all, according to what you've told us. So we very much thank you for doing that. So what we've done is, as you heard, that we did our background in the beginning, and now many of our panelists will be presenting interesting cases. And part of this is also to get some of your feedback as well, because we view this as something that is for our community together, which includes radiologists, endocrinologists, surgeons, cytopathologists who do ultrasound. So it's for all of us. So with that, I introduce my friend, Dr. Mark Lupo, who will challenge us some more.
All right, thank you, Susan. So I'd like to take a slightly different approach to this when asked about identifying challenges as a community-based endocrinologist focused on thyroid in the United States and in Florida. And I'm sure my issues are not unique to Florida. I wanted to look at it just as a community-based view. And the challenges we see are as clinicians are inconsistent ultrasound reporting. We see that the ACR TIRADs, despite being out for 2 years, are not being used consistently or efficiently. Often words are being used instead of the TIRADs category systems. Things like moderately are somewhat suspicious, or low suspicion, high suspicion, and often not correlating to a specific recommendation or biopsy recommendation or follow-up if biopsy is deferred. And I've been impressed with the job, or at least our local radiologists have done with BIRADs, and I'm hoping as we improve this over time and get more experience that we can see that with a TIRAD system. Endocrinologists and surgeons, clinician-performed ultrasound, they typically are using the American Thyroid Association, which is more of a pattern-based system, but also doing so inconsistently, often not saying it's ATA, but just using things like low, medium, or high risk. So we have a lot of work to do as clinicians and radiologists and as colleagues communicating with one another. Additionally, in the suboptimal reports, I would include lack of descriptive features. Franklin showed an example of just a solid nodule amenable to biopsy, and that's often we look at the images ourselves and we're seeing calcifications or patterns of margins that might be concerning, and these are often left out of the ultrasound reports. Susan mentioned the importance of real-time ultrasound clips, either if you're not doing this yourself, being able to go back to Cine loops, which can help with some of these, and also very consistently with what I see in the community is a lack of a description of the solid component in mixed solid cystic nodules, whether or not it's an eccentrically located solid component or concentrically, and when it is an eccentric solid component, which is more concerning, a lack of features such as calcifications or Doppler flow. And then an overcall of echogenic foci as microcalcifications, so the snow globe effect with the internal debris that we see in cystic nodules or the cystic component of nodules. Comet tail artifacts within cystic components are often interpreted as microcalcifications, and spongiform nodules. So we all have seen these spongiform nodules that on static imaging can be somewhat confusing as these echogenic foci here could look like microcalcifications, and some ultrasound equipment might be more pixelated that might make things look like microcalcifications. And additionally, in the spongiform nodules, we know there's a non-discrete border, but it's not an invasive border. But I see radiologists on these static images often calling these borders lobulated or irregular suspicious borders, and I see descriptions of these echogenic foci that we know are either posterior acoustic enhancement behind microcystic changes or comet tail artifact as microcalcification. So it's important, again, if you're only, and a lot of our community-based endocrinologists only will do what the radiology report says. So they read the radiology report, and they say 2.1 centimeter nodule with microcalcifications. They go right to biopsy, and they go back to radiology for biopsy, and then they get biopsied, and it was a spongiform nodule the whole time. So if you have the opportunity to look at the Cine loops or to do the imaging yourself, it's much more valuable. And in the US, for those of you who aren't familiar with our system, this is done by technicians or sonographers, and mostly static images, more and more frequently Cine loops, but often the clinicians are getting reports by radiologists who have never seen the patient or done the exam themselves, and the sonographers are taking static images of what they think is most important. So where we see this as or even more major problem is the lymph nodes. So we all know that it's important to look at the lateral neck and visible central compartment when we're doing thyroid nodule evaluation, but most radiology reports don't include this, so any guideline needs to emphasize this. The sonographers in the US are not routinely trained to identify cervical neck lymph nodes. And let me show you an example of where this was important. This was a 19-year-old female that I saw after her initial surgery, and she was referred for a left upper cystic, left upper palpable mass, and she was young. They thought it was a branchial cleft cyst. They did the CT scan and ultrasound, both showing this cystic lesion here. And the ultrasound was just to evaluate the neck mass, so it focused on here. You can begin to see the upper lobe of the left thyroid, and they even mentioned that it's superior to the left lobe. And this is, again, another image before her surgery. You see a nice image of the left lobe with a microcalcification, hypoechoic nodule, clearly concerning for that's a TR5. It's high risk on any of our classification systems, but this was the image the sonographer took, image presented to the radiologist, and this was all that was focused on. So they went right to surgery without biopsy, and that was, of course, papillary thyroid cancer, and then I got to see the patient afterwards. So not ideal, and I think if we train our sonographers, we'll have better outcomes with this. So too many unnecessary biopsies. I think a lack of pattern recognition in patients with thyroiditis is important, and I think we could do a better job at helping people understand some of the fibrosis and heterogeneity that we see in thyroiditis, autoimmune thyroid disease, and avoid unnecessary biopsies, such as the tubercle of Zuckerkandl, et cetera, because unfortunately, as the pathologists know, you biopsy these thyroiditis glands and you get atypia, and atypia will lead to unnecessary molecular marker spending and potentially unnecessary surgery. Categorizing nodules as higher risk, we've talked about, and I think we can probably expand the thresholds for biopsy in some of the lower and potentially intermediate risk nodules and do less biopsies overall. But there are lots of opportunities here to standardize the ultrasound reporting, which is what our goal is, and to mandate the assessment of the lateral neck, and to help our sonographers who are part of our team to do comprehensive lateral neck and to report that on the final neck ultrasound report. And then when we are adopting a new system within a department, to encourage consensus conference to make sure we have consistent utilization within a group of radiologists or clinicians who are reporting ultrasound, to make sure there's a reproducibility and to minimize some of that interobserver variation that we see. So those were my comments on challenges from a community-based clinician. Thank you very much.
Thank you, Mark, and I apologize on behalf of radiologists everywhere, but seriously, we have a lot of work to do. And the reason we're presenting this, clearly we're really just getting underway with this effort, is we want to hear from the community about what's missing and what can help you. With that, I invite Dr. Na to do his presentation.
Thank you. Yes, I have two cases which may be not clearly answered by the current guidelines, ultrasound or risk stratification systems. Okay. So this is a case of a 71-year-old female with a palpable thyroid nodule. There is an entirely calcified nodule with a dense posterior shadowing, and as an isolated macrocalcification pattern. And the size was 14 milliliter. Well, what would be the next step? If there is not any suspicious metastatic lymph node, then what would be the next step? Biopsy or follow-up? Any answer from the panels?
Probably I would try to assess two US features here. First, I would turn on the Doppler, not for risk stratification, but certainly to be able to determine if there is a solid part behind the calcification, because there is a doubt here. It's a little isoechoic just behind the calcification. And then second, I would look for a breach in the calcification to determine if I can have a needle, a small needle at least, in that breach.
Okay.
That's what I would do.
Any other different idea?
Well,
or
probably with a transisthmic approach, with an acute angle, it's possible to enter along the medial part of the nodule that seems to be devoid of calcification. Anyway, even if there is no clear extrusive growth, there is, as was told before, some isoechoic tissue behind the central calcification. So I would say that a fine needle could be appropriate.
So, Dr. Pepini, your suggestion is for biopsy?
Yes.
Not just follow-up? Okay.
So
Any other? Okay.
I think this is an older nodule in an older patient.
Yeah.
And I think, in my experience, I don't like when I look at these nodules, because I know that although technically you will be able to find a breach and you will probably come from the transisthmus approach, and you can see that it's probably in maybe the inferior aspect of the nodule on the sagittal image that you might be able to find that breach on the transverse view. If you do get your needle into that 3 millimeter area, which is technically possible, you tend to get back colloid debris and macrophages, and these tend to be older nodules in older patients. She is 71 years old, usually maybe the sequelae of cysts, and I have yet to biopsy one like this without true extrusion that's malignant. And I think you point to something very important, because perhaps we will have enough to be able to classify nodules like this, and my own practice has been, if I don't see those suspicious features, to leave this alone. And I already had talked about this older patient anyway, but even if this patient were a little bit younger.
Okay, thank you. Okay.
So can I just add from the otolaryngologist perspective, what I would do next on this patient is perform a laryngoscopy, only because you can't really see posterior to this lesion. It looks like it's probably confined to the thyroid, and the patient may not present with hoarseness, but one thing I wouldn't want to miss would be something invading posteriorly, which at least I could assess by laryngoscopy on clinical exam.
Yes, it's an important point. Usually in the large, entirely calcified nodule, it is very difficult to assess the posterior or a medial margin of the calcified nodule just on ultrasonography. As you commented, this kind of entirely calcified nodule is not clearly classified by the current risk stratification systems. But as far as I know, in the ACR system, it is categorized as intermediate risk nodules, and also it is categorized as having intermediate risk in Korean TIRAS. But the other guidelines, it is not clearly defined. Anyway, okay, let's go on. Okay. Okay, sure.
Maybe.
I might see like 10 patients like this every week. I have a very small practice, but I do see 10 patients.
They're bringing a microphone
Yeah.
to you, so.
Yes, comment.
A comment from the community, from a small practice. I see like 10 patients a week like this one. I don't think they deserve laryngoscopy. And I would like to ask you, what is the risk of this patient really having a clinically meaningful cancer? I think this risk is very, very, very low. That's why I do not even do ultrasound follow-up of these patients. I just ask the
really?
GP to palpate the neck, and that's it.
Okay.
And I don't think that I'm doing a lot of harm.
Okay. I think it could be controversial, and we may need more evidence and studies. Okay, let's look at this case. Okay, CT scans were obtained after biopsy. And as you see, this nodule is compactly calcified nodule in the right thyroid trough on CT scan. And also at the initial assessment with ultrasonography, there was suspicious metastatic lymph node in the right lateral neck, level 4. As you see, hyperechoic nodal echogenicity, and also intranodal macrocalcifications. Also, CT scans shows strong enhancement of this level 4 lymph node. So in these patients, there was suspicion of metastatic lymph node. We decided to further biopsy workup. Okay. And in this case, we performed core needle biopsy and fine needle aspiration. The core needle biopsy result was indeterminate lesion with nuclear atypia, and the fine needle aspiration result was non-diagnostic. And the fine needle aspiration of lymph node was follicular cells with focal atypia, and tissue thyroglobulin was 31.3. So finally, after surgery, the final pathology diagnosis was invasive encapsulate follicular variant PTC, and there was a minor extrathyroidal extension and macroscopic lymph node metastasis, and pathologic staging was T1B and N1B, M0 clinically. And the postoperative risk was ATA intermediate risk. So this case was a follicular variant PTC manifested as isolated macrocalcification. Okay. Okay. Any comment?
Yeah, we all thought that we heard there were that there were no lymph nodes.
Yeah.
You told us.
Dr. Mandel, excuse me for this. I have a problem when someone says that 71 is old. Okay. I mean, if a nodule is found on Donald Trump, no one is going to do an FNA. I mean, if this was my father, I would like to do an FNA. People are living longer now. I think maybe when you stratify the risk, you need to take into consideration two things. One of them is the medical condition of the patient, and the other thing, the part of the country the patient is coming from. For example, I come from Jordan, and I see so many cancers in Jordan. I mean, it has nothing to do with the age. It's like it's growing and growing, and the cancer, I mean, in general.
So this nodule, and we apologize because most of us here didn't hear, we thought the lymph nodes were normal.
Yeah.
So one of the things is always to look at the lymph nodes, and in a patient like this, so a 71-year-old patient with a nodule like this, when you find an abnormal lymph node, this would be somebody for which you would recommend biopsy. I think the decisions about doing an FNA when someone is older, and I just choose 70 because that is the cutoff that was in this paper, and 70 is a cutoff, or 75 is often a cutoff that is used for colonoscopy. Certainly, biologic age can be different than chronologic age, but it comes down to, what was it? What was the thing that Jerry Freeman quoted this morning that used to be said about the surgeons, the poison matching the
punishment should fit the crime.
So what we're talking about is not so much the goal of diagnosing a cancer itself, but something that would otherwise change that person's life so that it might otherwise shorten it. If you're going to do that, why aren't we doing prostate biopsies on everybody who has a rising PSA when they're 74?
But we discuss with the patient.
So it can't, which would say it can be a discussion.
Yeah.
I said, though, but that age should at least be used as a potential modifier, in addition to someone who's 50 years old who may be getting some type of therapy, systemic therapy for another systemic malignancy, where their general life expectancy now, because of, let's say, checkpoint inhibitors now has gone up to 4 years, and you find an intermediate risk thyroid nodule. What is the likelihood that that is something that would meaningfully impact their life over what might otherwise be the 4-year span? So it was just the idea of introducing this into the context of the entire patient, and how is that going to mean, what you find, what is the potential for that to meaningfully impact whatever the quality and duration of that patient's life would be, and it's always a discussion with the patient.
Thank you.
Okay.
It depends on what country you're in. I don't.
Yeah, it varies. Let's keep going.
Okay. Okay, thank you for a comment. And I understand the last comment, but as you know, it should be personalized and yeah, to the patient. So it depends on the a personal decision and the physical status and comorbidity, I think so. Okay, let's go on the next case. It's my last case. The second case, okay, this is a 65-year-old male, less than 75. Okay, this patient has a neck swelling and bilateral cervical lymphadenopathy. So this patient first visited not endocrinology, but some ENT surgeons. So there is diffuse enlargement of thyroid gland, as you see, and diffusely heterogeneous echogenicity of thyroid, predominantly isoechoic, and somewhat focal areas of hypoechogenicity. And there was clinically pathologic lymphadenopathy in both lateral neck. Okay. In this case, there was clinical suspicion of something malignant disease. So neck CT scans were performed to evaluate the whole entire neck. So as you see, there were multiple lymphadenopathy or suspicious malignant lymph nodes in both lateral neck. And also, a non-contrasted CT scan shows diffuse loss of normal thyroid attenuation, and also enlargement. And also, enhanced CT scan shows mild enhancement of diffuse thyroid lesion. And this is not a normal enhancement of thyroid gland. And there was also a multiple non-necrotic lymphadenopathy in both lateral neck with mild enhancement. Okay, what would be the most possible pathology of the thyroid lesion? Any answer from panels? Okay.
Can we go back to the first image?
Okay. This is the ultrasound images of thyroid gland.
Well, the feeling is some kind of diffuse involvement of the thyroid parenchyma.
Yeah.
And so, well, of course, we can have even unusual involvement, but, well, it's not so hypoechoic, otherwise we could think about a diffuse sclerosing papillary cancer, but it's rather, well, I would say not so markedly hypoechoic. And, well, otherwise...
Yes, it's a very good suggestion. Yes, it is not specific, but yes, it's not typical, maybe not typical of sclerosing variant of papillary carcinoma, but possible diagnosis, I think so. Any other comment or?
I agree with Enrico. It is suggestive of the diffuse sclerosing variant of papillary carcinoma, but the patient's age doesn't fit with that as well. You see this more commonly in children with thyroid cancer with more extensive lymphadenopathy, but this patient has a very diffuse process in their thyroid and diffuse lymphadenopathy. I think you do have to be thinking about non-thyroid malignancies such as lymphoma.
Yes. I agree. And I'd like to indicate that the lymph node pattern, maybe ultrasonography, it is non-specific, but on CT scans, it is not typical of metastasis from thyroid cancer. And a relatively homogeneous mild enhancement is not typical of metastasis from thyroid cancer. Okay, so anyway, we performed quantitative biopsy. Actually, I performed this procedure for the left thyroid lesion and the right lateral neck lymph node. And the pathology diagnosis was squamous cell carcinoma metastasis based on histologic findings and molecular and some immunohistochemical studies. And there was clinically a lung mass with multiple lung metastases on just a CT and PET-CT scan, and the final clinical diagnosis was lung cancer with thyroid metastases. This is a case of thyroid metastasis manifested as diffuse infiltrative region in the thyroid, probably from lung cancer. Okay. Any other questions or comments on the floor or panels? No? Okay, thank you.
Dr. Lisa Orloff, our surgeon.
Thank you. Well, as others have mentioned, Franklin just asked us to submit cases or things that we thought might be representative about what we're trying to accomplish here with this project. And if I can, do I advance the slides here? I just thought of brought a few recent case examples as the sort of end user of this ultrasonography process and the clinician who gets to see and be directly involved with the final histology of patients with these lesions. I have questions that remain sort of open and some limitations that I see with all of our reporting systems or sort of pattern recognition systems. So this first case is a fairly convincing suspicious lesion by any of the systems that have been described today. This is a solid, very hypoechoic, taller than wide, irregularly shaped nodule, and it doesn't have obvious intranodular echogenic foci, but this was biopsied and reported as a suspicious lesion, suspicious for malignancy. And this case turned out to be a medullary carcinoma, and it was associated with suspicious lymphadenopathy, like the previous case that was presented, and it brought to my mind the fact that systems such as the Thyroid system do not include metastatic or suspicious lymph nodes or even examination of the lymph nodes as part of the assessment or stratification of risk of thyroid nodules. So that was something that I think we have differences across the world in terms of using serum calcitonin as a screening biochemical study. And at least in the United States, calcitonin is not routinely used in the workup of thyroid nodules. And this would be something that I'm hoping we're going to discuss as a panel, is when you have a non-specific diagnosis of malignancy, we don't want to forget the less common medullary carcinoma and discuss when it may be appropriate to consider serum calcitonin testing as part of the workup. So that was one case. The next case was a teenage male with a 5-centimeter nodule. This nodule, by the Thyroid system, would actually not have qualified for a biopsy at all, other than the fact that it was 5 centimeters in size. So I think that sort of superseded the point system. But this was a solid, mostly solid, yet partially cystic nodule. And by Thyroids, I think we have different points assigned for mixed solid and cystic, and mostly or nearly completely solid. And I found myself struggling with how to define this, what percentage of cystic composition qualifies as mixed cystic and solid versus mostly solid. So that was one characteristic on this nodule that gave me trouble. The echogenicity here, I think, is hyperechoic, and the lesion was wider than tall, the margins were smooth, it did not contain echogenic foci, it was biopsied as an atypia of undetermined significance. Here is the Doppler view, and sorry, I'll go back there. The final surgical pathology on this nodule was follicular variant of papillary carcinoma, non-encapsulated. So just again, if we had not proceeded to surgery based on the size of this nodule, we might have missed that diagnosis of malignancy. And so this is a question that I think we're hoping to incorporate into our improvement in inter-observer communication, as well as just more precise definitions, as Gilles mentioned. A third case here was a patient with a lesion here that you can see in transverse and sagittal view. Here's another picture with Doppler. And this lesion was also described as atypia of undetermined significance by fine needle aspiration biopsy. It brings up to me the challenge of a nodule that has ill-defined borders. And I think by the TIRAD system, ill-defined borders yield no points on TIRADs. And I think that we can sometimes struggle with what is an ill-defined border versus what is an irregular border. And oftentimes, as one of the cases that Mark showed, ill-defined borders are common in nodular hyperplasia or coalescent nodules or benign nodules, but also this nodule proved to be a papillary carcinoma that had other suspicious features, such as the calcification or echogenic foci or focus that was present. But borders are not always as easy to find as we would like. Here's just I don't know if I'm able to play the video on this. Or, there we go. So just an example of challenges with borders of nodules. And just the same nodule in a sagittal view. This nodule was also relatively isoechoic, and that added to the difficulty identifying the borders of the nodule and distinguishing it from the surrounding thyroid tissue. So, and then finally, a case of a Bethesda 4 follicular lesion of undetermined significance. Again, you have a mixed solid and cystic nodule, defining the percentage of cystic that might garner one set of points versus another is a factor that I already mentioned. This nodule, here's a video of this nodule, and this nodule, I don't remember the exact size, but it was certainly the dominant nodule in this thyroid, and because of its Bethesda 4 categorization and its size, it proceeded to surgery. But what in fact turned out to be the significant nodule, that turned out to be a follicular adenoma, and we do have a lesion, and I don't know if this is pointer here, right here, a lesion just medial to the dominant nodule in the isthmus. Here's the dominant nodule, and here's the isthmus nodule. This was a 0.6 centimeter papillary carcinoma that was included in the lobectomy, but had not been biopsied because of its size. But I show this case to emphasize, I think, the importance of the location of a nodule within the thyroid. And this is something that is not included in any of the staging systems. And we know that the isthmus does not have as much surrounding parenchyma to prevent a nodule from becoming extrathyroidal. I think some of the cases that were presented early highlighted that. And so I'm hoping that in part of this discussion that we're anticipating that we will look at the location of a lesion within the thyroid as well. So that was all I had to say.
Thank you.
Mm-hmm.
And Dr. Papini is going to talk to us about a really important topic to close. I have just a few slides at the very end after his presentation, but he's going to talk to us about interobserver variability. Enrico?
Many thanks, frankly, and congratulations to the heroes that in a hot Roman afternoon still here, and it's a pleasure. Well, my presentation is focused on the problems that we still have with the current classification systems. We can be glad because this is a study from our group. We see that we have an excellent definition of the malignant class, but unfortunately, we have also some problem This is a paper from the group of Filetti, and we can see that we have an excellent opportunity with the different systems to avoid a substantial number of biopsies. But we must say that the majority of these data are originated from single centers. And we have just a few multi-center data, and intra-observer study are rather poor. And so we should consider the inter-observer agreement between different high-volume thyroid center, and also between endocrinologists and radiologists, because there is probably some maybe different approach, different equipments, different techniques that may create a differentiation. And so this was the study, and we used the UTRAD's Lexicon, basically 100 electronic images that were histologically proven, and 7 different experts from 3 different Italian centers. All the 3 centers were high-volume centers. And after 1 month, we performed a new assessment on the randomized images. And so we evaluated these 5 ultrasound features and these 4 ultrasound classification systems. And as you can see, we have results that are rather consistent with the data that were presented before. That is, the margins are a relevant problem because there is a great difference in the definition of the margins, and the greatest difficulty was between the radiologist and the endocrinologist. And if we match this data with a single center study, we see that we are much more pessimistic with the multi-center study than with several single center studies. And certainly there are several others that I apologize I didn't include in this slide. And you see that thyroid nodule classification systems were, well, probably here we have a bias because it was Italian, and probably there was more confidence in the mostly used Italian classification. But anyway, you can see that the Cohen's K is not very satisfactory. And you see again that anyway the results in this multi-center study was definitely worse than the results of the previous year study in one of the same centers. And finally, well, even the intra-observer agreement was not so satisfactory, because when the same persons examined after randomization 1 month later, as you can see, we have again a not satisfactory result on margins, while we can say that we are quite satisfied for composition, echogenicity, macrocalcification, and microcalcification. And finally, still there is an intra-observer agreement that is not completely satisfactory. Of course, again, there is probably a bias for this classification that is due to more complete information. And so we can say that at the moment, the agreement between different centers for ultrasound features ranges from fair to moderate, that is not completely satisfactory. The lowest consistency was found for nodule margins, and the greater variability was registered between endocrinologists and radiologists. The Interobserver agreement for the ultrasound classification system was better because ranged from fair to moderate, and it was definitely more satisfactory for ultrasound findings. And so this demonstrates that a unified classification system and a dedicated training for using this classification system is very important because, as you have seen, the variability in a country that uses some kind of classification is much lower than with the other classification systems. Thank you.
Thank you, Enrico, and we definitely have our work cut out for us. We know that. In the last few minutes, I just want to talk about some other considerations, some of which have been mentioned before. Flow, elastography, and AI, or artificial intelligence and radiomics, which is machine-based analysis of images. Starting off with a little bit about flow, and I'm not going to go into any detail about these, but there has been some work with showing that vascularity, we heard some of this earlier at the meeting, that especially with our newer tools looking at fine vascularity within lesions, that it can be helpful, although it's not included in most of the risk stratification systems now. It's something we may need to look at. This is one study that showed that the so-called vascular fraction area of the central portion of nodules was helpful in predicting malignancy. Similarly, there's been some use of contrast-enhanced ultrasound in nodules. I think this will probably get somewhat less traction because although it's fairly easy to do, in fact, in the United States, contrast was approved relatively recently compared to the rest of the world. I don't know that this will ever be a routine tool, but it's something that could be considered in nodules that are particularly problematic. Elastography similarly, although as Gilles mentioned earlier, we're not including it in the lexicon at this point. We are going to, I think, have to discuss it at some point because like as shown in this study, elastography, looking at the stiffness of the solid portions of nodules, has been shown to have some value, and in this study reduced the number of unnecessary FNAs. And here's another study that showed that elastography was helpful in classifying nodules. Now I'm showing this image. It's a picture of a woman staring at her crystal ball over here, and I use that to indicate that predicting the future, especially in relation to technology, artificial intelligence and radiomics can be tricky. And to highlight that, I show you two quotes. This is from Mr. Alex Lewitt, who was president of a vacuum cleaner company who predicted that nuclear-powered vacuum cleaners would be a reality in 10 years. This was in 1955, and I think we could all say quite happily that this didn't come to pass. And an even better quote, I love this one. 2 years from now, spam will be solved. Bill Gates in 2004. And in fact, the latest estimates show that about 60% of email traffic is spam. So we've gone in the wrong direction since 2004. So where are things going to go with artificial intelligence? It's being applied in many fields. It's a hot topic in radiology. A couple years ago, an expert in the field raised a lot of concerns just before a major radiology meeting when he said that we should stop training radiologists because they'd be replaced by computers. He's since backed off that a little bit, but where are we going to go? There has been some work that shows that machine learning and AI are helpful. In this case, radiomics scoring analysis of images by machine learning was helpful and improved the performance of junior radiologists. And this was some work that I was involved with folks at Duke University, where we used AI to modify the ACR TIRAD system and improve it. So just for fun, I'm going to show you this clip about AI from 1984. This is from the first Terminator movie, and if you may recall this, Arnold, as the Terminator, walks into a bar and he's trying to find, doesn't have any clothes on, he's trying to size somebody up to find the right size clothes, and this is a perfect match. So will we ever apply this in thyroid imaging? Well, maybe. And you can see the readout on the bottom left. We have a target-rich environment, nodule acquired, cystic and solid, macrocalcifications, isoechoic. I'll be back with a needle. Now, are we really going to get to that? I don't know, but I actually do think, all kidding aside, that artificial intelligence has a lot of promise in nodule classification. Because you heard a lot about, especially from Enrico's last talk, about interobserver variability. That's because we humans are looking at images, and it's certainly possible that machine analysis of images where they're not, the algorithm isn't particularly looking at whether there's microcalcifications or macrocalcifications or looking at the margin, but the overall gestalt of the image, all the features that can be analyzed in a different way from looking at individual features may be able to perform better than humans in that regard. I don't know that for sure, but I do know that if we disregard the possible application of this technology, we'll not be doing a service. So with that, I'd like to thank you for your attention this afternoon. I also would like to thank the steering committee of the WCTC for giving us the time to present this. As I said earlier, this was very much a grassroots effort and is very much a work in progress. I'd like to thank all my co-conspirators on the steering committee, including the two who weren't able to be at the meeting. We have a lot of work cut out for us, but we really want to hear from you. That wasn't just, I wasn't just saying that for effect. We want to know what you need in risk stratification systems, and by all means, let us know. So again, thank you very much, and have a great evening. And we do have a couple minutes left. If anybody has any questions or suggestions, please, I think a microphone is headed your way.
I wanted to know about Elastigirl.
Oh, okay. I don't think I really answered that, but yes, please.
I think it's a great effort that you guys are doing, but I think since you're doing this, I think it should not just stop at ultrasound. I think what you should also have is somewhere in your recommendations that what a radiologist or an endocrinologist should write on the report or on the requisition slip for a cytopathologist or a pathologist to look at. Because what we suffer from the other end as a cytopathologist is no information is provided about the nodule. And believe me, most of us do know when you have the ultrasound lingo, we do know what does it mean. And also on the other side, what you should expect from the cytopathology report. Because having a diagnosis of just suspicious for malignancy without any classifiers is not acceptable, because that's what not the Bethesda system says. So I think if you're doing this effort, I think you should bring it full circle by including this in your recommendation also.
Any comments from the panel? Yeah, I don't know, to be honest, whether our cytopathologists in Birmingham look at the ultrasound reports, which are our reports, even though there's interobserver and interobserver variability, follow a very well-defined template and give very detailed descriptions of the nodules. I think that is important to know. Any comments from the group?
I certainly appreciate the comment, and I think it relates to documentation and communication. And the final point to that is feedback, because I think we all, if we only see a patient and their thyroid at a certain phase in their care and we don't get the follow-up on what was the ultimate result and outcome of that patient, either if it was a surgical histologic result, relating that histology back to what our initial impression of the nodule was, we won't be able to improve what we're doing unless we get that follow-up. And so I think, same with the fine needle aspiration biopsy, having that feedback into the improvement of the sonographic characterization.
But you know, the
Yes.
So when I'm sitting on a surgical column bench, I do look at the radiology to correlate that that's the nodule that was
Yeah.
biopsied.
Yeah.
Because as you showed, there was a case where there was a small nodule
Yeah.
that was not biopsied. So
Yeah.
for me, it is very important
Yeah.
because sometimes you have metastatic lymph nodes from that small cancer, not the larger one that you
Yes.
biopsied. So I think it is very important to include those in your papers because your papers become universal.
Yeah.
These recommendations and read by everybody. So I
Yeah.
think it should not be done in silo. You should have that included. Just a
Agreed.
recommendation.
Yeah, no, thank you.
Thank you. Any other comments or questions? And you can find us very easily on, I'm on Twitter, email. I really do want to hear comments from the community. So again, thank you very much for your attention.